Invite Dr. Anadi Keshi. Dr. Anadi is consultant vitreoretina surgeons from the Virat Eye Hospital located in the Virat Nagar, southwest part of the country. And he has been working as a consultant VR surgeon for this hospital about 5 years, I guess, for 5 years, and doing very well in the region. He will be sharing his experience in diabetic retinopathy. Dr. Anadi, please.
Good afternoon, everyone, and thank you, sir, for your kind introduction. And today my topic is on diabetic retinopathy, and more than my experience, I think I'll be discussing on why we need to think this entirety differently. So I have nothing to disclose. And we all know that diabetic retinopathy is among the fastest emerging epidemic globally and affects the macro and the microvascular components of the different target organs, and one of them being the eye. So we already know, I'm not going to discuss much about this. We all know the baseline characteristics, the risk factors, the stagings, the comorbidities, complications, and the treatment. And we also know the treatment outcomes of different agents, such as anti-VEGFs, steroids, lasers that are used. And even despite the treatment, if the patient is not following the discipline properly, we know how the outcomes are. And I think COVID-19 has taught us a very valuable lesson that, if we, what happens to a diabetic patient if they are lost to follow-up, or if we rely too much on anti-VEGFs than the lasers. So even after so much understanding, the outcomes of all the diabetic retinopathy patients are very, very variable. So we have to question ourselves that do we have to create better monitoring parameters? Because if the treatment is if we approach it in a blanket way, or if it's so well established, then why are there so much variations in the clinical outcomes? And again, there's a differing results. Then, if not, then what more? Are we, in the previous presentation, we talk about artificial intelligence and the AI. So are we relying too much on the machines? Because the AI should be not an artificial intelligence, but we being humans, it should be actual intelligence, not an artificial intelligence. So are we being too dependent on imaging or investigations? So these are the places where we lead. So screening, diagnosis, staging, and we have become so good at confirming, reconfirming, reconfirming, and again, doing it over and over again. And we, of course, know the treatments. So, and we do have the standards set by the ICO and PPP, the preferred practice pattern by the AO regarding the follow-ups. But then, if we look inside, there still seems to be a missing factor. And again, as I said, have we become too dependent on the technology? And recently there is a term coined vomit, which means the victims of modern imaging technology. So are we, putting our patients into a vomit category, and are we still following the fundamentals as we are becoming more and more dependent on the technology? So basically, to the very basics, I'd just like to ask the audience, how many of you send for HbA1c? I think everyone does that. But then how many send for hemoglobin? Very few, or almost none. Then, is it necessary or not? Because it's very, very important that you should understand that if the hemoglobin is not correct, or if the patient is anemic, then the patient is already at 2 times risk for retinopathy and 5 times increased risk for pre-proliferative or proliferative retinopathy. So, this is what the research has already shown, and I think that's the fundamentals, because the HbA1c is dependent on the HB, and there is already established data which says that up to 0.2 to 0.4 gram% of HbA1c can be affected by a decrease of 1 gram of hemoglobin, and lower hemoglobin have a higher HbA1c at the same fasting glucose levels, consistent even across the non-diabetic range of fasting glucose, plasma glucose, meaning that if we are taking HbA1c in a patient who is anemic, we might be falsely labeling that as diabetic patients if we don't check the hemoglobin. So, with this, we performed a small study, and we correlated the hemoglobin levels and glycated hemoglobins with the severity of diabetic retinopathy. And again, this is our work recently we've been doing. So we are introducing DIARY, which means the Diabetic Retinopathy Risk Index, with an introduction of the HB to HbA1c ratios, and which we think could be a noble indicator for predicting the severity of diabetic retinopathy. So this is our methodology. We take the patients, we take the fundus pictures, then we grade them. We check the the hemoglobin and the HbA1c levels. Then patients who have received previous treatment or with patients with renal impairment and anemia are excluded from the study. So altogether, we evaluated 224 patients, and 66%, almost two-thirds of them were male. And the mean hemoglobin was 12.7, and the HbA1c 8.76. So, if we look into the data, then we found that comparing throughout the different stages of the diabetic retinopathy, hemoglobin levels were fluctuating. So if you can see, it does not have a very linear relationship, and actually where you would just predict the hemoglobin to even drop further than they were having higher hemoglobins. This is probably, the patients, when they reach, by the time they reach the very severe NPDR, their physicians might be over-treating them or treating them more aggressive. So they might be correcting in the terms of hemoglobin levels, and similarly HbA1c levels as well. It does have some linearity, but not a very practical or a very easily interpretable linear relationship. So as I just mentioned, they're not really linear and very hard to predict. So with this, we introduced the DIARY scale. Again, it's the Diabetic Relative Risk Index. So over here, what we basically do is HB to HbA1c ratio. So these were the various ratios, and if you compare throughout the different classifications of the diabetic retinopathy, you can see that it does have a linear relationship. So for mild, it was 1.84, so HRPDR 1.21, somewhere in between, it's 1.62. So what does this really all mean? So this is a DIARY scale. So 1.84, we create a scale like this, and we have the mild, moderate, severe, and PDR. So how will it help? So let's put the system to a test. So a patient who is a clinically moderate NPDR with no CSME, then follow up as per the IC or the PPP, it's up to 6 months, or it can be extended to 9 months. But then you do HB to HbA1c ratio, then you find that the patient has 1.47. But if you look at the DIARY, and if it's a moderate, that patient should be having a 1.71. The range should be somewhere there, but it's observed is 1.47. So it means that the patient is somewhere between moderate and the severe, diabetic retinopathy grading. So what does this mean is that the patient is in the coming days is more likely to be pushed towards the severe than stay in the moderate or improve. So this means we have to rethink about the follow-up. Maybe even if we put this patient into a general category and say 6 or 9 months, maybe because of the observed DIARY value, this patient would require a follow-up earlier. So again, putting a second test. So there's a patient who has come with a PDR, then we do a PRP, anti-VEGFs, metabolic, and the endocrine workup. Then, the follow-up is variable in such cases because they are the PDR cases. But then, in this patient, the observed DIARY HB to HbA1c is 1.72. But again, if you look at the PDR, the expected value would be 1.21. But here, if you look into the values, then you think that the observed values are actually better than you were expected. So you would generally expect this patient to be doing better than the other patients. So this patient might have, a better sugar control and maybe have a relatively lower risk of progressing into a PDR or HPS. So you can really comment on a certain extent on the prognosis. Then this is another scenario where a patient might not be evaluated by an ophthalmologist, but only a physician. But then they do an HbA1c to HB. Then if you take this, the observed HbA1c alone is not alarming because it's somewhere around 1.7, 1.7. But then you observe the DIARY is 1.47. Actually, a first person, usually a patient with 7.5, we don't think it's an alarming thing. But then if you look at this DIARY, then it's 1.46. So it's somewhere around the moderate to very severe. So, we all get the point what this is trying to say. So we have been doing validation at our center and along with other 15 centers regarding if this is really, does it correlate well or not. So using Octa and OCT images, we have been getting very concrete data. But then, it will be over time, and we will need a lot of data to actually confirm and to actually validate all of these points. So to conclude, the diabetes is very well understood, but the management still, I think we all, just by looking at this, do think that the management may require revision. HbA1c levels remain one of the most reliable predictors of glycemic control, but then, this finding further elaborates why hemoglobin should also be considered in managing the treatment of a patient with diabetes and diabetic retinopathy. So basically, back to the fundamentals, keep your basics very sharp, because HB and HbA1c, they are interrelated. We have gone through over time by time, and in our med schools and in biochemistry. So if hemoglobin levels are not to be considered along with the HbA1c, the desired target levels to slow down or halt the progression of the diabetic retinopathy may be better understood with using the diary. And diary could be one of the very first biomarker. It's not a very hi-fi or a very, a very high-tech thing. It's just using the basics to just realign yourself and treat the patients better. So noteworthy take-home message will be that the diary paves path to translate clinical findings into clinical guidelines, and we can also help in customizing the treatment, because sometimes we do have to ask that why and how are our two patients, when they are falling into the same category and receiving the same treatment, have different risk of progression in the diabetic retinopathy. So with this being said, the guidelines for follow-up and management with integration of the diary should be thought of than applying a blanket approach based solely on staging of diabetic retinopathy. For that, of course, I would be looking forward to collaborate with multiple centers, national and internationally, to perform a large multi-center validation for diary. And this is, I, in long term, do believe that it would not just save the eye from the damage, but limit the damage from happening itself in the first place. With this being said, I would like to thank you for your kind attention. Thank you.